Hello and welcome to chapter 14. This one is about nervous system disorders, and as a neuroscientist, this is one of my favorites. So, why don't we get started and start talking about these? Okay, so first of all, we're going to start off with a review of the nervous system. Here, I have my handy dandy little book here so that we can go through the figures together. So the nervous system composes the brain and the spinal cord. So the things with nerves, right? So your brain is your central area, and then the spinal cord is going to be connected to obviously the brain, and that would be the central nervous system. So think of it in the center, hence central. Peripheral means like the outside, so it's kind of like your peripheral vision is on the outside, right? So your peripheral nervous system is going to be the branching off from that spinal cord and the brain, right? So that's going to include your cranial and your spinal nerves, your sensory neurons, as well as your neuromuscular junctions. So looking at this wonderful picture, this is going to be figure 14.1 on page 327 of your book. And this is the overview of the nervous system. And so the nervous system is divided into two components: the central nervous system, again, which is composed of the brain and the spinal cord. So in this picture, the it looks like it's the yellow, but no, actually it's not. It's the central part here. I was going to say all the yellow, but then it branches off. So the brain and the spinal cord is going to be your central system. And then the peripheral nerves, remember, are those on the outside or the periphery. And these contain the cranial and spinal nerves, as well as the ganglia and the sensory receptors. So you can see a close up here of, looks like the skin from the arm. And so the peripheral nervous system, again, is going to be like those sensory nervous systems or the sensory receptors in the skin. And if you look at a cross section of it, you can see that you have the enteric plexuses in the small intestine. So that would be, again, part of the peripheral nervous system where you're kind of receiving information from all over the body. So the brain is used for communication, and it is the control center of the body. The brain's very important because it receives, it processes, and it evaluates inputs that it's receiving. And then it has to decide or think about what action we need to have taken. It's going to then initiate a response. And a lot of these are involuntary reactions, which are actually good for us, right? And so this is to maintain homeostasis, and this is regulated by the autonomic nerve system. So that's like making your heart beat or breathing. You don't have to think about it. It's involuntary. And it's a good thing because I kind of have the attention of a gnat and like on Red Bull. And so if I had to remind myself to breathe or have my heart beat, oh, it would be a disaster. So anyway, but so those are involuntary, where our voluntary actions are ones that I'm asking my body to do. I can sit here and say finger go up and down, right? So that's voluntary. I'm asking myself to do something. Okay. And then you have reflex activities, like if we're walking through the house at, I don't know, say 2 o'clock in the morning, and we step on a Lego and your foot just goes immediately up, or if you touch a hot stove, like I'm known for doing, then those are going to be our reflex activities. So, to talk about the brain specifically to start out, because this is kind of like what rules everything, right? So, first we have to protect it. Okay, and we have a lot of protective mechanisms. You have the skull, you have these meninges, which we're going to talk about, and then we have the cerebral spinal fluid, which is coming up here too. And all of this is kind of just like a cushion, so that if I go like this or I headbang because I'm awesome like that, just kidding. You guys can laugh. That's completely fine. Um, my brain's not smushing up against my skull, right? There is a little bit of buffer in there so that we're not just slamming like the thing that keeps us alive. Okay. So those meninges are like the dura mater. And so this would be the outer layer, which is the closest to the bone. Then you have your subdural space, sub meaning under. So subdural space would be underneath the dura. Then you have your arachnoid, and this would be that middle layer, and it's kind of webbed. And so that's how I think of it, like as arachnoid is like a spider web. So it's an arachnoid membrane, and it's more like not wavy, wispy or webby like, and we'll see pictures. And then you have that subarachnoid space. And subarachnoid would be underneath the arachnoid layer. And the subarachnoid space is actually what's going to contain that CSF, or that cerebral spinal fluid that I mentioned. It has a lot more uses than just cushioning your brain. I mean, it gives you nutrients, it gets rid of debris and metabolites. It's very, very, very important. And then we have the pia mater, and this is going to be what adheres to the surface of the brain. So looking at the meninges, this is very similar to the figure that is on page 328 of your book. It's figure 14.2. And so again, you have the skin, and then you have your muscle, and then you have your periosteum of the bone, and then you have your dura mater, your arachnoid mater, and then your pia mater. So DAP, your DAP, dura, arachnoid, and then your pia mater. And then in between you have those spaces, the epidural space, when you get like an epidural injection, or yeah, for giving birth, etc. That's on your spinal cord, but that's like the same spacing, right? Epidural. You have a subarachnoid space, sub meaning below. Below what? Oh, the arachnoid. And then you have, like, again, that P mater. So you can see it's just kind of stacked, right? And then so those are the meninges. And they're very important because they keep things in place where they're supposed to be. They help with nutritional transfer and a lot of other things. So when we talk about protecting the brain, again, we kind of do this at all costs, right? If I go like this, it might hurt a little bit. Obviously, I didn't smack myself that hard, but I mean, it's not going to hurt me, right? It's not going to hurt my brain. And that's because we need to protect it because, again, it's controlling everything that I do. It's controlling my memory recall of this information that I learned in grad school, right? Like, I'm a neuroscientist, and I graduated with my PhD back in 2005. So it's allowing me to recall this information. It's allowing me to put together a sentence structure, usually halfway decent. Sometimes you never know. And just a lot of other things. So we really need to protect that brain because our brain is us, right? So the one that we talk about the most is that CSF, the cerebral spinal fluid, because this provides a cushion for the brain and the spinal cord. And this is similar in plasma in appearance. So it's clear to slightly yellowish, but it should not be cloudy or anything like that. Cloudy means that you might have like meningitis or you have a bacterial infection. So it needs to be clear, not cloudy, and it might have a slight yellowish tinge to it, but mostly it's very translucent. So it is different in electrolyte, glucose, and protein concentrations when comparing it to plasma. The change in characteristics of CSF is a diagnostic tool. If they think that you might have meningitis, they do a spinal tap, they pull it out. If it's cloudy, you have an infection, right? Things like that. It's formed constantly by the choroid plexus, that like 80% of it is lining the lateral ventricles of your brain. There is a little bit made in the the third ventricle and other places, but the majority of it is in the choroid plexus of the ventricles, the two lateral ventricles. And then it flows through the ventricles into that subarachnoid space. And there are equal amounts of CSF that are needed to be produced and reabsorbed to maintain normal intracranial pressure. So I studied hydrocephalus, right? And so hydrocephalus is um, usually a blockage of the flow, or sometimes from a tumor. It can be from an overproduction of CSF, etc. But when we have this constant flow going through, we need to make as much as we're going to reabsorb, or else you're going to get too much, cause a headache and some problems, increase in ICP, or you're going to get too little, cause a headache, decrease in ICP, intracranial pressure, right? So we just need to keep that homeostatic level. So here are some characteristics of normal CSF, and this is on page 329, and this is table 14.1. And so again, it's clear and colorless. Sometimes it might have a slight yellow tinge, but we'll just call it clear. The pressure for normal is between 9 to 14 millimeters of mercury, and this is equivalent to 150 millimeters of water. There are no red blood cells. white blood cells only occasionally, usually if you're fighting off something, so that's why it's used as a diagnostic test. Your protein, sugar, and salt concentrations and potassium normal. Then your specific gravity, your pH is right around 7.3, and the volume at any given time is only 125 to 150 milliliters. But if you see the volume formed within 24 hours is about 5 times that, right? What that means is we form, filter, recycle about 5 times the amount that's in our brain at any given time. So that means that we have to have good reabsorption pathways, or else we would have some issues that can lead to like hydrocephalus, etc. Oh, sorry. So, other forms of protection that we have is the blood-brain barrier. And this occurs at the level of the capillaries in the brain. And this is important because it's going to limit the passage of materials into the brain. And it controls the balance of those electrolytes, glucose, and proteins in the brain. Fat soluble, those lipid soluble substances can easily pass through. And this is poorly developed in babies. Okay. Now, the blood-brain barrier is also very important pharmacologically because we have to develop drugs or any other things that we want to have go into the brain to be able to pass through that barrier, right? Because it's like number one defense of stopping things. So pharmacologically, I mean, we can have a drug that works great, like on the lower systems, but if it can't go into the brain, and that's where we need it to actually work, then it's not going to be an effective drug. We also have the blood CSF barrier, and this is located deep in the inside of your lateral ventricles at the choroid plexus, and this controls the constituents of CSF. So what is going, like the composition of it, what's going into it, what is it? All right, so moving on to the functional areas of the brain. We're going to talk about the cerebral hemispheres, the diencephalon, the brainstem, and the cerebellum. This starts on page 328 of your book. So there are some major functional areas of the brain, and this is table 14.2, and that's found on page 330 of your book. And so this is obviously very small, so use your book, but basically you have your area over here and you have your function. So it breaks it all down to the frontal lobe, the parietal lobe, the occipital lobe, the temporal lobe, the cerebellum, the medulla oblongata, the hypothalamus, the thalamus, the basal nuclei, the reticular activating systems, as well as down at the bottom, your limbic system, which is going to control your emotional responses. So this is a really good summary, and this would be great to, take each of them and put it into a flashcard. So with those cerebral hemispheres, these are the largest, most obvious areas of the brain. There's a longitudinal fissure, which is basically like a canyon, right? It's not a hole, but it's a divot, right? Or a demarcation. And the longitudinal fissure is going to separate those two hemispheres. Um, the left hemisphere to the right hemisphere. We have a cortex, which is going to consist of gray matter, and this gray matter is the nerve cell bodies. Then you have the corpus callosum, and this is where the white matter is. And this is where those myelinated nerve bundles or the tracts are. And these are going to connect the two hemispheres. Now, the reason why we have the myelinated nerve bundles on the nerves, right, are because myelination makes the signal go faster. So it's kind of like insulating fiber optic cables, right? And so that's how I remember that that's the white matter because your oligodendrocytes, which are going to be making that myelination, et cetera, it's just kind of like it's a whitish color. And so that's why it's called white matter because it actually physically looks different, where the cell body itself, the neuronal cell body, is going to be more of that gray area. Okay, so just think of color. It's literally because it's wrapped with myelin, and myelin happens to be whitish. Okay, so that's how you can tell the difference between gray matter and white matter. And each hemisphere is divided into 5 major lobes. You have your prefrontal, your frontal, your parietal, your temporal, and your occipital lobes. Okay, so your right and your left hemispheres are similar in structure, but not necessarily function. You do have a dominant hemisphere, and this would be the side that controls the language. So usually this is the left hemisphere in most people, but it can flip-flop, okay? You also have Broca's area, and this is very important because this is where we have our motor or expressive speech located in our brain. And then you have your Wernicke area, and this is the integration center. And this is where we're going to be able to comprehend the languages that we receive, hear, process, and go from there. The prefrontal cortex, this is going to coordinate the complex cognitive behavior. And this is where we have the components for expression of personality. You have your basal nuclei, and this is part of the extrapyramidal system, or the EPS. And this controls and coordinates the skeletal muscle to lead to and make us be able to do activity. You also have your limbic system, and this consists of many nuclei and connecting fibers, and this is responsible for those emotional reactions or feelings. You have your thalamus, and this is the relay station for the incoming sensory impulses. Additionally, you have your hypothalamus, and this is the key role in maintaining homeostasis of the body. And so remember, from day one, we have really stressed what homeostatic levels are. Hypothalamus is key, okay? So this is going to control the autonomic nervous system and much of the endocrine system, and it's going to work, to regulate the body temperature, the fluid and the food intake, a regulation of our sleep cycles, our stress responses, our emotional responses, and our sex drive. And then we have our epithalamus as well. So looking at this picture of the brain, this is going to be showing you the functional areas of the brain. And this is found on page 329, and this is figure 14.3. And so again, we just looked at those areas, the frontal lobe, temporal lobe, etc. And so it's going to tell you where our different characteristics are controlled. So our intellect and personality is going to be in that frontal lobe. That Broca's speech area is here. We have our motor cortex, you have our sensory cortex, auditory where we hear, the Wernicke's area, our memory here, right? Our cerebellum is going to be for balance, equilibrium, and coordination. All right, so this is a great little summary of what we just talked about on the previous slide. Well, our brain stem is also very important, and this is the connection that is located between the brain and the spinal cord. And the brain stem is composed of the midbrain, the pons, and the medulla oblongata. The midbrain is the most superior, or like highest, right, of the brainstem area of the brainstem, and this is a reticular formation and reticular activating system, otherwise abbreviated as RAS. And this is the network of nuclei and neurons. And this is going to be found throughout the brain stems, those nuclei and the neurons. And the midbrain is connected to many different parts of the brain. This determines the degree of awareness of the cerebral cortex. And drugs can affect the reactivity or activity of the reticular activating system, and therefore they can increase or decrease input to the cerebral cortex and the diencephalon. So you can manipulate this on purpose, right, or pharmacologically. The pons, this is the bundles of afferent and efferent fibers, and the pons is basically the bridge that is there between the cerebellum and the cerebrum. And there are several nuclei of the cranial nerves that are located here. The medulla oblongata, this is the control center for respiratory and cardiovascular function. It also helps to coordinate the cough reflex, our swallowing, and our vomiting. And sorry guys, there's also the location of nuclei for several of our cranial nerves. The cerebrum, this is dorsal to the pons and the medulla. So I think of dorsal as like dolphins' dorsal fins, right? So it's like kind of behind. The functions are to coordinate movements, maintain our posture, maintain our equilibrium, to receive input from the pyramidal system, and it also is going to receive input from the proprioceptors in our muscles and joints. So proprioception is like how if I close my eyes and I go like this, I know my hand is out to the left. I know that it's up to the right. It's like your sensation, your knowing of location of your body parts is proprioception. Okay. So it's going to receive the input in your muscles and joints, and then it's also going to receive input from visual and vestibular pathways. So how do we do blood supply to the brain? And this is on page 331. Well, we have our internal carotid and vertebral arteries that are going to supply blood to our brain. Each internal carotid artery is going to be able to divide into an anterior and a middle cerebral artery. That anterior cerebral artery is going to supply the frontal lobe, where the middle cerebral artery is going to supply the lateral part of the cerebral hemisphere. And then you have your basal artery, and this is going to be formed by our vertebral arteries. Our basal arteries, this is going to be supplying branches to the brainstem and the cerebellum, and it divides into the right and the left posterior cerebral arteries. You also have the circle of Willis, and this is an arrangement that's formed by the anastomoses between the major areas, and it's provided by the anterior communicating artery between the anterior cerebral arteries, and also the posterior communicating arteries between the middle cerebral and the posterior cerebral arteries. I had to go grab a sweater and a kitty. So this is the same. So, anyway, okay. So our blood supply to the brain, we have our basilar arteries, and these are going to be supplying branches to the brainstem and the cerebellum. And again, it's redivided into right and left posterior cerebral arteries. That circle of Willis we talked about. Yeah, so okay, I'm back. Oops. The blood flow in the cerebral arteries is relatively constant. Okay, we can't have stagnant areas, or else we could it's not good, because you want to be having nutrients being taken away. Pooling blood can lead to clumping or clotting. Clotting can lead to strokes, right? So we just want to make sure that we have a constant blood flow. This is auto-regulated. Okay, so kind of to that same homeostatic thing, right? Our body does a lot of really good things on its own. So the autoregulation is, so if it detects increased carbon dioxide level or decreased blood pH, a decrease in blood pressure, these are all going to result in immediate local vasodilation. And so vasodilation, remember, is when those veins, right, are going to dilate or get bigger. And so that means that more blood can whoosh through and take care of that. Okay. We also have baroreceptors and chemoreceptors that feed in and help to make sure that this is, again, stays at that homeostatic level. The baroreceptors, those are pressure. Think of barometric pressure. And chemo, it's chemicals, right? So pressure and chemical receptors. Again, it's all going to work together to try to make that homeostatic level. We also have our venous blood that's found in our brain, and that's going to collect in the dural sinuses, and this is going to drain into the right and the left internal jugular veins. So moving on to our cranial nerves. There are 12 different pairs, and these are going to originate from various parts of the brain. They're numbered from ventral to dorsal, and the cranial nerves may contain motor fibers only, sensory fibers only, or both motor and sensory fibers, and these would be considered mixed nerves. So here is a good table. It's table 14.3 on page 332 of your book, and these are major components of the cranial nerves. So again, this would be great to break down and turn into a different flashcards, because you will need to know your cranial nerves. Okay, and so it tells you the number, the name, the type of fiber, and the function. And so put a big star by this, because yes, you will need to know these. So what about spinal cord and spinal nerves? Okay. So your spinal cord starts on page 331 and your spinal nerve starts on page 333. So what is your spinal cord? Well, it is protected by the vertebral column, also your meninges, and your CSF, that's cerebrospinal fluid. And this is continuous with the medulla oblongata. It ends at the lower border of the first lumbar vertebrae, and it's going to extend as a bundle of nerve roots, and these are called your cauda equina. It is consists of white matter and gray matter, and that gray matter is going to be in the core. It kind of looks like a butterfly in a cross section, and so we'll just see that coming up. The gray matter, remember, the white matter is like the axons. The gray matter is the actual cell body itself. So you have, when you look at the gray matter, and again, that it looks like kind of, like I said, a butterfly. It has the anterior horns, and this would be the cell bodies of the motor neurons. You have your posterior horns, and this would be your interneurons or your associated neurons. And then you have your lateral horns, and these would be the visceral and motor neurons. So looking at this is figure 14.4, and this is an overview of the spinal cord. And so you can see that up here is going to be that brain stem, and the parasympathetic fibers, which would be your cranial nerves 3, 5, 6, 7, 9, and 10. You have your phrenic nerves here, and this would be the phrenic nerve to the diaphragm, and these are the ones that control respiration. These are the ones that control your arms. These are your intercostal muscles, and these control your respiration. These would be your sympathetic nervous system, which would be your heart, your blood vessels, and your temperature. Down here you have the lumbar ones, and these are going to, and sacral, and these are going to control your legs. And then down here you have your parasympathetic nerves, and this would include your bowel, bladder, and your external genitalia. So we talked about this a little bit before, so let's talk about it in more depth. We are going to talk about our white matter. So with the white matter, you have afferent, which would be your sensory nerves, and you have your efferent, and those would be your motor nerves. Okay, I'm trying to see where they have this in your book. And they are going to be organized into different tracks. Each track has a unique position in the white matter, and the name of the track, this is kind of very true in science. They name it for what its purpose is, okay? So the name of the track is going to be based on the source and the destination. And so if you have ascending tracks, this means that they're going to be going from like the spinal cord to the brain, where descending is the brain to the spinal cord. So ascending is taking from the spinal cord and ascending up to the brain, where descending starts up at the brain and descends down to the spinal cord. So here is a cross section of the spinal cord that can show those tracks, okay? And this is going to be on page 333. Again, it's figure 14.4. And so you can see that you have your facialis gracilis, or the dorsal white column, that's ascending from touch and pressure receptors in the skin. You have posterior fissure. Remember, fissure is kind of like a canyon, right? You have your dorsal horn, you have your posterior spinal cerebral tract, you have your anterior spinal cerebral tract, and this is going to ascend from the proprioceptors in the muscle and tendons for position and sense. You have your vestibular spinal tract, your anterior cortical spinal tract, your tectal spinal tract, etc. Okay, so this is a great little cross section of the spinal cord and showing you how important it is in all of the different areas that it's going to help encompass and control. So our spinal nerves, this is on page 333. You have 31 pairs of spinal nerves, and they are named by the location in the vertebral column where they emerge. Each nerve is connected to the spinal cord by roots, and we have these ventral or anterior roots, and these would be your motor efferent fibers, and then you have your dorsal or your posterior roots, and these would be your sensory or afferent fibers. So what are reflexes? Reflexes start on 333 and go to 334. These are automatic, rapid, involuntary responses to a stimulus. we have a sensory stimulus. And this can occur from, or this is from the receptor, and then it's going to be conducted along the afferent fiber. Then it hits the synapse, and this is in the spinal cord or the cranial reflexes in the brain. And then it starts an efferent impulse to elicit the response. So this is going to be connecting the inner neurons, right? So that we can basically take a signal and shoot it through the body to get a response. And this is going to transmit sensory information to the brain. So I just drank some coffee and it's still a little hot. The other day I drank coffee and I forgot I didn't put an ice cube in it and it was very hot. So a reflex was to, like get it back out. Okay, so I didn't like choke and scald my throat. And so I put it back into the coffee cup, right? But that would be a reflex. Also, we have, well, that cat that you just met is my stepdaughter Caitlin's cat, and he's living with us with her for a little bit, and he leaves toys everywhere, right? So if we get down up in the middle of the night and we're walking through the house and we step on a toy, your reflex is to pick up your foot, right? Because it's just trying to keep you from stepping on it and hurting yourself. Um, okay, so what about neurons and how we actually conduct impulses? And so this is on page 334. So neurons, I love neurons. These are highly specialized non-mitotic cells, and they conduct impulses through the central nervous system, which is abbreviated CNS, as well as the peripheral nervous system, which is abbreviated PNS. And these are going to require glucose and oxygen for metabolism. Okay, sugar, your brain runs off sugar. The cell bodies and the processes are called axons or dendrites. The axons are going to be the ones that are conducting impulses away from the body, where the dendrites, this is the receptor site, and they take the impulses toward the body. So axons go away, like you're throwing an axe away from you, where dendrites, they're coming towards you. Nerve fibers may be covered in that myelin sheath that I was telling you about a little bit earlier. So the myelin sheath, this insulates the fiber. It speeds up that rate of conduction. This is formed by Schwann cells in the peripheral nervous system and oligodendrocytes in the central nervous system. Can you tell I studied the central nervous system because I said oligodendrocytes earlier? Okay, but regardless, Schwann cells and oligodendrocytes, what they're going to do is they wrap it in a myelin sheath. Okay, there are gaps that are between the myelin sheaths, and these are called nodes of Ranvier. And so basically they're like, it's like playing leapfrog. You guys are probably too young to know what leapfrog was, but you jump like signal from one to one to one, and so it jumps those nodes of Ranvier. And the axon collaterals may also emerge. Glial cells, these are supportive cells in the central nervous system. And I kind of, when I was in grad school, I studied astrogliosis, right? So this is what my PhD was on. And so I kind of called them nurse cells because they're very supportive, supportive cells in your body, and you need them. So we have astroglia, and these contribute to the blood-brain barrier. You have oligodendroglia, and these provide myelin for the axons in the central nervous system. You have microglia, and these are our little Pac-Man phagocytes, right, that are going to take away damaged cells and debris. And you have your ependymal cells, and these are going to line the brain ventricles and the neural tube cavity. And these form part of that choroid plexus. So what about if we have damage to our neurons? Can they regenerate? Well, if the neuronal cell body is damaged, then the neuron dies. Okay. In the peripheral nervous system, axons may be able to regenerate. And after the damage to the axon, there is the section that's distal to the injury degenerates. Distal means below, degeneration means it dies and goes away. Okay. And then what can happen is the Schwann cell can form a new tube at the end of the remaining axon, and then the cell body becomes larger to synthesize or make additional proteins for the growth or the regeneration of the axon. So it's kind of a gray area, sort of, right? So there's a lot of stem cell studies going on for spinal cord regeneration, but usually if you kill a neuron, it's kind of dead forever. Okay. So what about the conduction of impulses? And this is on page 334. So the stimulus is going to increase the permeability of the neuronal membrane. It can be depolarized by a sodium influx, and then we have a generation or the start of an action potential, and then it's repolarized, and this is going to be caused by an outward movement of potassium, and then the sodium potassium moves ions into the normal position. What does this mean? This means keep your electrolytes where they're supposed to be, right? So your body nerve impulses, it's kind of like a slingshot, right? So you like ramp up and you're ready to go. And once you like let go, then that would be the release of the action potential. And then an action is going to occur. And then when you go to repolarize the cell, you're kind of like cranking it back and you're about ready to load up again. And so all of this depolarization, the generation of an action potential, any muscle contraction, everything like that, it's all based on your sodium, your potassium levels, and how they're moving across membranes. It's fascinating. Like I love action potentials and talking about all of that stuff. Anyway, all right, so keep your electrolytes where they're supposed to be. And then these myelinated fibers, these are saltatory conductions, and these, remember, the myelination causes it to be much faster, and so these are rapid conduction. So what is a synapse? Well, a synapse, this is a presynaptic axon terminal. And so basically we have vesicles, which are just little pockets that contains the neurotransmitter. That's the chemical. Neuro for the brain, transmitter is the signal, right? And so these vesicles are called synaptic vesicles because they're found in the synapse, right? You also have a synaptic cleft, and then you have a postsynaptic receptor. So, like, the synapse is kind of like a space, right? So it's like you have the synapse and then you have the nerve, right? And there's a space in between them. And so then these neurotransmitters, once they're released, then they travel in that space, right, in that synaptic cleft to go find the receptors, right? So they're not like, I don't know, it's very, very, very small, but there is a small space, and then it's all your whole body is based on the, action potentials from all of these synapses and all that. That's so cool. All right, what is a neurotransmitter, or what would happen with a neurotransmitter? Well, this is when it's going to be released into the synaptic cleft on the stimulus. It's going to be inactivated by enzymes or reuptake into the presynaptic axon. We also have postsynaptic neuron dendrites or cell bodies that can depolarize depending on the neurotransmitters that are present. And all of this is going to be talked about again on page like 333, 334 and 335. So the neurotransmitters at the synapse, there's a diagram 14.5 that shows all of the different ones. Apparently they're not in the slide deck downloaded from the book. So anyway, but you can see that this is going to be showing you what's happening in that synaptic area. Oh, this is funny. Okay, anyway, on the preview, it's absolutely empty. Here, I'll show you guys. You really don't care, but I do. So if you can see the preview, you can see over here, it shows nothing. But then when the slide shows up, it shows it. So intriguing. Okay, so what are some examples of neurotransmitters? Well, we have acetylcholine, and this would be excitatory. And this is found at the neuromuscular junction. It's in the autonomic nervous system and in the brain. We have norepinephrine and epinephrine, and these are excitatory. These are found in the brain as well as in the sympathetic nervous system. We have dopamine and serotonin, and again, these are excitatory and they're found in the brain. We have our GABA neurotransmitters, and this is our gamma aminobutyric acid. It's abbreviated GABA. These are inhibitory and they're found in the brain. You also have glycine, and this is inhibitory, and this is found again in the spinal cord. Okay. So let's go back. So with our autonomic nervous system, was trying to see if there was a summary of your neurotransmitters, but I do not see one. So that would just be a good thing to make your own little flashcards. Okay. Anyway, the autonomic nervous system. It has both sympathetic and parasympathetic areas. They have motor and sensory innervation, and these are involuntary, so they happen without us thinking about it. We have antagonistic effects, and this is where they can work against each other. But basically, these are important because it maintains homeostasis. So we have branches that have those antagonistic effects. Some of these would be our preganglionic fibers in the brain and the spinal cord, or our postganglionic fibers, which are outside of the central nervous system. Alrighty. So speaking specifically about our sympathetic nervous system, this is going to be on page 335. Okay, this is what controls our fight or flight response, and it's going to increase the general level of activity in the body. We have our preganglionic fibers, and these arise from the thoracic and first two lumbar segments. The ganglia are located in the chains or the trunks, and we have neurotransmitters, which include preganglionic and postganglionic neurotransmitters. The preganglionic, or the ones before the ganglions, are going to be controlled by acetylcholine, and the postganglionic ones are going to be controlled by norepinephrine. We also have our receptors, and these are going to be our alpha and our beta receptors. Okay, so this is a close-up of what can happen, and this is part of that figure on 14.5. And so basically what happens is when you have your sympathetic nervous system, that's part of your spinal cord, you have an impulse that's going to travel, and then acetylcholine is going to be released. That's the neurotransmitter, and it's going to transmit the signal then to the postganglionic nerve. The impulse is going to continue to travel down, and then that causes the release of norepinephrine. And then this norepinephrine is going to be, joining with the receptor, therefore generating an impulse. Okay, and so this is just kind of what happens. And again, this is C in that figure on page 14.5. And so your impulse is going to be like electrical, and then it turns into chemical, and then it's electrical, then it turns into chemical again. So you can see they're very closely related, and they have to work together in order to make these signals and our muscles move. And the cool thing is, guys, this happens like so much, and we don't even have to think about it. Your body's just so amazing because it does all this stuff without us even like knowing. Okay. So moving on to the parasympathetic nervous system then, and this is starting on page 337. This is originating in the brainstem and the sacral spinal nerves, and this is going to dominate the digestive system, and it also aids in recovery after a sympathetic activity. The ganglion is going to be scattered and close to the target organ. Our neurotransmitter, again, that we use for this one is going to be acetylcholine, and this can both be presynaptic and postsynaptic, so before the synapse and after the synapse. And our receptors are nicotinic and muscarinic. Okay. So looking at the parasympathetic, again, this is part of that figure 14.5 on page 336. So again, you have your brain, you have your impulse, that's going to go on your preganglionic nerve. It releases the acetylcholine, then it jumps to the postganglionic nerve, continues that impulse, and then here it's going to release the acetylcholine, and again, the receptor is going to be stimulated and continue on that impulse. So it's the same principle, but just different chemicals that are being used. So this is table 14.4 on page 337, and this helps to summarize the effect of stimulation on the autonomic nervous system. And so in your areas, you have your receptors, and then what happens with the sympathetic versus the parasympathetic. So, for instance, with the cardiovascular system, we have our heart blood vessels. Our receptor would be beta 1 cells. The sympathetic stimulation would cause an increased rate and force of contraction, and then the parasympathetic activation would cause a decreased rate and contractility. Okay. Alpha 1 causes vasoconstriction, beta 2 causes vasodilation, right? So this is just a really good summary table on the different receptors and the different effects that it's going to have. So what about general effects of neurologic dysfunction? Well, we have our local or focalized, right? So local, focal, same thing, effects. We have your tentorial and infratentorial lesions. You have your left and your right hemispheres. You have your effect on loss of consciousness. You have motor dysfunction that can arise. You have sensory deficits, visual loss, language disorders, seizures, increased ICP, herniation, and diagnostic tests. So there are lots of different effects that neurologic dysfunction can cause. Okay, so some of those local effects are going to, okay, so this starts on page 338. So the local or focalized events relating to this can be, the signs are related to a specific area of the brain or spinal cord in which the lesion is located. An example could be paresis or paralysis of the right arm, and this results from damage to a section of the left frontal lobe, okay? So you harm the left frontal lobe and it can cause paralysis in the right arm. We also have expanding lesions, and these, as they grow, right, it can be caused by a growing tumor or a hemorrhage. You also have additional impairment that's noted as adjacent areas become involved. You have your supratentorial and infratentorial lesions. Our supratentorial lesions, these occur in the cerebral hemispheres above the tentorium cerebri, and these lead to a specific dysfunction in a discrete area. You have your infratentorial lesions, and these are located in the brainstem or below the tentorium. And these may affect many motor and sensory fibers, and these can result in widespread impairments. You also have respiratory and circulatory functions that can be impaired, and levels of consciousness can also be impaired. And so there's a small little paragraph on this on page 338, but all of it was basically outlined here. What about with your left and right hemispheres? What happens if there's neurologic dysfunction here? Well, if we have damage to the left hemisphere, then this can cause a loss of logical thinking and ability, of analytical skills and other intellectual abilities, as well as communication skill losses or deficits. If you have damage to the right hemisphere, this is going to impair the appreciation of music and art. It can cause behavioral problems. It can cause spatial orientation and recognition of relationships may become deficient. And then it can also cause self-care deficits, and these are common. So what about our level of consciousness? So again, this is on page 338. So we have decreased level of consciousness or responsiveness that can occur, and these are early changes that are often noticed in acute brain disorders. There are levels of reduced consciousness, and these may lead to confusion, disorientation, memory loss, unresponsiveness to verbal stimuli, difficulty in arousal, or loss of consciousness or a coma. So the GCS, right, Glasgow Coma Scale, you see this on like Scrubs, maybe not Scrubs, but ER, Code Black, best TV show ever. Like a lot of the medical shows, right? They talk about the Glasgow Coma Scale. And so this is the scoring system. This is on page 339. And so you have scores for eye opening and responsiveness, motor responses, verbal responses, and then your score. So 10 is good, right? And perfect, or I'm sorry, 15. And obviously, I think it's like when it's down 0, 2, 3, that's like pretty much brain dead, right? But anyway, you have your maximum, and then some examples of this person that's obviously declining. Okay. Um, so when we're talking about our levels of consciousness, you have your vegetative state, and this is where we have a loss of awareness and mental capabilities, and these result from diffuse brain damage. And we also have stem functions that do continue, so you can still breathe, right? But you're not responsive. You do have an appearance of a sleep wake cycle, and but the person is unresponsive to external stimuli. We also have a locked in syndrome, and this refers to a condition in which an individual with brain damage is aware and capable of thinking, but they are paralyzed and cannot communicate. And so this sometimes people can blink their eyes or move their eyes for a yes or no response. So, what about the criteria for brain death? Cessation or stopping of brain function, and this includes the function of the cerebral cortex and the brainstem. You would have a flat or an inactive EEG, so electroencephalogram. There would be an absence of brainstem reflexes or responses, also an absence of spontaneous respirations when the ventilator assistance is stopped, so you're taken off the vent and you can't breathe on your own. Establishment of the certainty of irreversible brain damage by confirmation of the cause of the dysfunction. And you have to be evaluated twice by different physicians so that there's no bias. They really want to really make sure that you are brain dead before they terminate life. So, what about motor dysfunction? Well, you can have damage to the upper motor neurons, and this is going to cause an interference with voluntary movements. You can have weakness or paralysis on the contralateral side of the body. You can have damage to the lower motor neurons, and this can cause weakness or paralysis in the same side of the body at or below the level of the spinal cord damage. You can also decortate or decerebrate posturing, and this is going to be a result of a severe brain damage. So, what about seizures? Okay, these are actually pretty common. This is on page 341. The seizures are convulsions. These are caused by spontaneous excessive discharge of neurons in the brain. The causes can be inflammation, hypoxia, bleeding in the brain. It can be focal or localized and related to the particular site of the irritation, or they can become generalized. And these are often manifested by involuntary repetitive movements or abnormal sensations, which are considered to be auras. If you have generalized seizures, you can have absence seizures, which would be petit mal. You can have tonic-clonic seizures or myoclonic. If you have partial seizures, you can have simple partial or complex partial, and these are psychomotor seizures. You can also have continuous seizures, and this would be considered a status epilepticus, right? And this is where we have increased metabolism of glucose and oxygen. Basically, you don't come out of a seizure, and this may be life-threatening. So, what about intracranial pressure and what happens when you increase it? This is on page 341. So, the brain is encased in our skull, right? The skull is there, it's fixed after your, a toddler, your cranial sutures, I think they finish, like, what is it? They finish sticking by your teens, right? Sticking meaning not gluing together, growing together, right? Fissures. Um, so you can't compress your brain. So if I push really hard, I can compress the muscles and the skin around it, but I'm not actually changing the shape of my skull. Um, so because of that, our fluids, our blood, and our cerebrospinal fluid are not compressible. So if we have an increase in fluid or additional mass that can cause an increase in intracranial pressure, then basically it's going to be contained in the brain and it can't go anywhere. And so if it pushes up against that brain tissue, then ischemia and eventual infarction can occur from that brain tissue. Increased ICP is common in many neurologic problems such as brain hemorrhage, trauma, cerebral edema, infection, tumors, and abnormal circulation of CSF like hydrocephalus. So here is an increase of intracranial pressure in possible herniations. This is figure 14.8 in your book on page 342. So you would have a herniation of the cingulate gyrus underneath the false cerebri. That would be here. You could also have a tumor that can compress here. You could also have an uncal herniation of the temporal lobe into the tentorial notch. You can have a cerebral herniation, or you could have a downward displacement of the brainstem through the tentorial notch. So basically, when you have anything growing in there that's not supposed to be growing on there, remember, it's a fixed system. So if it grows, your brain tissue and the other things there either going to get squished out or squished up against. And so that would cause, obviously, some not so pleasant side effects. So here are some effects of increased ICP, and this is on page 342, table 14.7. And so general signs would be decreasing levels of consciousness and headache, vomiting, increased blood pressure, etc. And then this would be the reasoning why it might be happening. So early signs of increased ICP, if the cause is not removed, then we can have decreasing levels of consciousness or decreased responsiveness, which would be you're lethargic, right? You could have decreased pupillary responses of your eyeballs. You can have severe headaches from the stretching of the dura and the walls of large blood vessels. This can cause vomiting, and this is often projectile and not associated with food intake. And this can result in the pressure stimulating the metric center in the medulla. And you can also have papilledema, and this would be caused by increased ICP and swelling of the optic disc. So here is a picture of the papilledema, and this is figure 14.9 on page 343. And so, yeah, so the papilledema is going to be there, and then you can actually, on the figure in your book, it actually shows the displacement and folding of the retina that is occurring is there. So, yeah. So remember, the papilledema can be observed by looking through the pupil of the eye of the retina, where the optic disc provides a window into the brain. The optic nerve is essentially a projection of the brain tissue surrounded by CSF and meninges, and it enters the eyes at the optic disc, where it reflects the effects of increased ICP in the brain. Those early manifestations continue to increase in severity as long as ICP continues to rise. Okay, that's on page 342. So what about our vital signs? Well, this can cause a development of cerebral ischemia, and this can be where the vasomotor centers respond and attempt to increase arterial blood supply to the brain, kind of like a Cushing's reflex. You can also have systemic vasoconstriction, and this would be an increase of systemic blood pressure where you have more blood to brain to relieve the ischemia. You can also have a baroreceptor response, and this can occur in the carotid arteries, and this is where increased blood pressure is occurring by having a slowing heart rate. You can have a chemoreceptor response, and this is how we can respond to low carbon dioxide levels and also a reduction in respiratory rate. This can also have improved cerebral circulation, and this can relieve the ischemia. This is a short time, and also we have increased ICP that causes the ischemia to reoccur, and then if this happens, the cycle will repeat. If ICP continues to rise, then blood pressure rises, and then this increased pulse pressure is significant in people with ICP. So having studied hydrocephalus for a long time, a lot of times these patients have increased intracranial pressure, and they can just feel everything pulsing, right? And so the blood pressure rises, you can feel the pulsing in your blood, you can feel the pulsing in your head and your eyes and everything. It's incredibly uncomfortable for these patients. This is figure 14.10, and this is where vital signs can change with increased ICP. So you can see that your systolic is going to increase, the pulse pressure, diastolic also increases a little bit. Your pulse can go down over time, your respiration goes down under time from the irreversible damage that can potentially be happening with the increase and ICP over time. Right. Okay, some visual signs would be pressure on the ocular motor nerve, which is also cranial nerve 3, and this can affect the size and the response of the pupils. The pupil ipsilateral to the lesion becomes fixed and dilated. As pressure increases, the shift of the contents across the middle to both of the pupils becomes fixed and dilated, and then you can also have ptosis, and this would be the droopy eyelid, and this may occur, and this is due to effect of pressure on the cranial nerve 3. Sorry, I just got up and walked around my house. Okay, so what happens with changes in cerebral spinal fluid? Well, the specimen can be produced by lumbar puncture. They can get it by poking you in your lumbar area and pulling it out. Pressurized CSF is elevated when the intracranial pressure is increased. You have composition of fluid, which may vary with causes, and the cerebrospinal fluid may be pinkish, and it can contain erythrocytes. If it's cloudy, deeper yellow fluid, then this indicates that there is a contamination with white blood cells, and abnormal protein levels may also indicate not contamination, but the presence of a neoplasm. So what about herniation? Well, we have transsternodal herniation, and this would be where you have your cerebral hemispheres, the diencephalon, and the midbrain that would be displaced downwards. And this can result from the pressure effects of flow of blood through the CSF, the RAS, and respiration. You can have uncal herniation. This would be where the uncus of the temporal lobe is displaced downward, and this is going to, in turn, cause pressure on cranial nerve 3, on the posterior cerebral artery, and on the RAS, the RAS. Then we have our intrafrontal or your cerebral or tonsillar herniation, and this is where your cerebellar tonsils are pushed downward through the foramen magnum. Foramen is a fancy word for hole, magnum is big, right? So the big hole, literally. And then this compresses the brainstem and the vital centers and can lead to an infarction, and this does cause death. So what are the different types of diagnostic tests that we can do? So this is on page 344 of your book. Well, we can do CT scans, we can do MRI scans, we can do cerebral angiography, you can use Doppler ultrasounds, you can use electroencephalography, and radionuclides can also be used to track perfusions of the central nervous system, and lumbar puncture is often used to check pressure and to analyze the cerebral spinal fluid. This is figure 14.11 in your book on page 344, and this is showing the procedure of the lumbar puncture. So cerebral spinal fluid is obtained by inserting a needle, as you can see here, into the subarachnoid space in the lumbar region. Okay, so moving on to vascular disorders. Okay, we have transient ischemic attacks, we have cerebrovascular accidents, and we have cerebral aneurysms. These may be hemorrhagic or ischemic, and they interfere with blood supply to a specific area. You have TIAs, which are trans-ischemic effects. Yeah, you see, okay. These are on page 346 of your book, and these may occur singly or in a series, and these do result from the temporary localized reduction of blood flow in the brain. The pathophysiology of it. Why does it happen? Well, it happens because you can have a partial occlusion of an artery. It's partially blocked. It can arise from arteriosclerosis. It can be from a small embolus. It can be from a vascular spasm, or it can be from the local loss of autoregulation. So some signs and symptoms are going to be directly related to the location of where the ischemia is occurring. You can have intermittent short episodes of impaired function, for example, muscle weakness in an arm or a leg, or you can have visual disturbances, and this can cause numbness and paresthesia in the face. You can also have transient aphasia, or confusion may develop, and repeated attacks may be a warning sign for an obstruction related to arteriosclerosis. Um, when we're talking about cerebral vascular accidents or strokes, this is going to be on page 346. This is an infarction of the brain tissue that results from a lack of blood. So it can be from an occlusion of a cerebral blood vessel or from a rupture of a cerebral vessel. 5 minutes of ischemia causes irreversible nerve cell damage, and a central area of necrosis develops, and all function of that area is lost. It can be surrounded by an area of inflammation, and this zone will regain function following healing. This is a picture of an acute hemorrhagic infarction, and this is on page 347, and it's figure 14.13. And so there was the external superior surface of the brain showing an acute hemorrhagic infarction. So notice the blood vessels on the surface of the brain. So this area, that's the dead or necrotic area, that would be what happened after the infarction. So there are different types of CVAs, cerebrovascular accidents or strokes. One is the occlusion of an artery by an arterioma, and these often develop in large arteries. There can be a sudden obstruction that's caused by an embolus, and this would be lodging in the cerebral artery. You can also have intracerebral hemorrhages, and this would be caused by a rupture of the cerebral artery in a patient with severe hypertension. The effects are evident in both hemispheres, and these are complicated or can be complicated by secondary effects of bleeding. So here is a fun summary table of the types of the cerebrovascular events, and this is table 14.8 in your book on page 346. So you can have predisposing conditions, the onset, the increased ICP, and effects. So thrombosis is predisposing condition, could be arteriosclerosis in the cerebral artery. The predisposing condition for an embolus could be arteriosclerosis or systemic effects such as a heart. You can see where my mind is. I haven't been able to ride because it's so cold out. All right, and then also you have your hemorrhage, and this can be predisposed by a high blood pressure or a narrowing of your blood vessels. Okay, so great little summary table. So what about the etiology? So your risk factors. This is on page 347. So your risk factors, so basically the MRI can determine the cause of the stroke. And your risk factors can include diabetes, high blood pressure, systemic lupus, erythematosus, arteriosclerosis, history of transischemic attacks, increasing age, obstructive sleep apnea, heart disease, smoking, or being a couch potato. Combining like the use of oral contraceptives and cigarette smoking can also cause this, and also congenital malformation of blood vessels or increasing age. So depending on the location of the obstruction and the size of the artery involved, the presence of the collateral circulation may diminish or reduce the size of the affected area. You also have a lack of voluntary movement or sensation on the opposite side of the body. And initially, you have flaccid paralysis, and the spastic paralysis would be developing weeks later. And then we also have an NIH stroke scale, and this was developed by the National Institutes of Health, and this is designed to assist in rapid diagnoses. Okay. So the NIH health scale is on page 348 of your book. If you want to read up on that a little bit more. So emergency first aid for stroke would be call 911 immediately and state that the person has symptoms of a stroke. The patient should be transported to a hospital as quickly as possible with recording of common drugs used and medical conditions that are being treated. Also, the time of onset of the stroke and treatment is directly related to the severity of the damage of the brain, and minutes count. So the quicker that you can get them there, the best. What about treatment? Well, they can use clot-busting agents such as TPA, and this would be the tissue plasminogen activator, And initial screening has to rule out hemorrhage or other contraindications before, the use of an anticoagulant drug is used. So the TPA is one of the mainstream ones if you're eligible for it. You could also do surgical intervention. You can use glucocorticoids. You can have supportive treatments. You can have occupational and physical therapists, such as language pathologists. You can treat underlying problems to prevent reoccurrences. And then also rehabilitation is going to begin immediately so that you can try to regain any loss of function. Um, so what about seizure disorders? Well, these are uncontrolled excessive discharge of neurons in the brain, and may be localized or generalized. There are two basic categories, and they are either generalized or partial seizures. There are many possible causes, and actually, they honestly, we a lot of times don't know what causes them. We're still trying to figure it out. And they are classified by their location in the brain as well as their clinical features. So, the pathophysiology of seizure disorders are going to be that is a sudden, spontaneous, uncontrolled depolarization of the neurons, and each seizure can last for a few seconds or for minutes. And your seizure disorders in your book is on page 367. EEGs during seizures can help indicate the type of seizure that the patient's having, and complications may arise from general seizures. You also have status epilepticus, and this would be continuous seizure without recovery of consciousness. Many seizure disorders are idiopathic, which means we don't know what causes them. Triggers of them are like they're nondescript almost of a way. Okay, so these are precipitating factors. They could have physical stimuli such as loud noises or bright lights. So like concerts that have strobe lights, or you're standing next to a speaker. Sometimes movies have strobes. Sometimes fireworks have strobes, right? Also, biochemical stimuli such as stress, excessive premenstrual fluid retention, hypoglycemia, so low blood sugars, change in medication, and also hyperventilation, so breathing, hyperventilating, right? General seizure patterns, you have some prodromal signs that can occur hours before the seizure. An aura precedes the loss of consciousness in many people, but not everyone. You can also have a loss of consciousness, but not everybody. Strong tonic muscle contractions can occur. Sometimes you can have a cry out, okay, that you can hear. You have a clonic stage that would follow. You have contractions that gradually subside, and then the person is usually confused and very tired with aching muscles, and they fall into a deep sleep, and this is the poststatical period. So there's no typical seizure, right? So this is for a very severe seizure, but like I have friends that have seizure disorders and they don't always pass out or whatever. So this is just a generalized pattern, but this is not everybody that has like epilepsy or seizure is going to follow every single one of these. Okay. So what about partial seizures? So this is on page 369 of your book. Partial seizures can arise from epigenetic focus, and this can be manifested by repeated motor activity, or auditory and visual experiences can also occur. And these can cause memory and consciousness problems, but usually for the partial seizures, the memory and consciousness does remain. Treatment is try to figure out what's causing it. Use anticonvulsant drugs, and once the seizure begins, it can't be stopped. Okay, so it's kind of like a palliative. You try to slow down your neuronal signaling so that your brain doesn't freak out and continue to do it more. But treatment's kind of like a mixed bag. All right, what about chronic degenerative disorders? This is on page 370, and these include multiple sclerosis, Parkinson's, ALS, myasthenia gravis, and Huntington's disease. So speaking specifically about MS or multiple sclerosis, this is a progressive demyelination of the neurons in the brain, spinal cord, and cranial nerves. So remember, myelination made the signal go quicker and easier. So demyelination would make things slow down, right? There are, different types of MS, and they have a variation of effects and severity and progression. You have the loss of myelin that can interfere with the conduction of impulses in the affected fibers, and these may affect motor, sensory, and autonomic fibers. And these occur in different patches in the nervous system. So this is figure 14.28 in your book on page 370, and this shows typical white matter changes around the ventricles that are shown in this MRI. So normally we don't have this super dense area of white matter here. It's more subdued, right? So it's definitely, that's a change that would occur in white matter. So the earliest lesions can occur, and they occur as an inflammatory response as cells that normally do not enter the brain or spinal cord. And when they do so, they attack the neurons with the loss of myelin in the white matter or the brain or the spinal cord. Okay. You can also have plaques. So basically later larger areas of inflammation and demyelination occur, and those areas are called plaques, and these become visible. And frequently they're beside the lateral ventricles in the brain, like we just saw, the brainstem, as well as along the optic nerves. And initially, the area of the plaque appears to be pinkish and have like edema, but then it becomes gray and firm. The plaques are going to vary in size, and several may coalesce or converge into a single patch. The initial inflammation may subside, and neural function can return to normal after a short time until another incident occurs. In time, the neural degeneration becomes irreversible, functions lost permanently. With each reoccurrence, the additional areas of the central nervous system are going to be involved, and multiple sclerosis varies in severity, occurring in mild and slowly progressive matters is in some individuals and rapidly in others. So this is on page 370. Okay. So we just talked about that. So the onset, this is under the etiology, usually occurs between 20 and 40 years of age. We really don't know the cause. It may be an autoimmune disease, it may be a nutritional deficit, it may be a change in blood flow to neurons. It may also have some genetic, immunological, and environmental components, and increased risks for close relatives do occur in relatives that are affected with individuals. And it also says the disease is more common in women by a 2-to-1 ratio. So that's kind of interesting. MS occurs more frequently in people of European descent. There's increased risk for close relatives. Okay. So basically, under signs and symptoms, we have manifestations, or how it occurs. It's determined by areas of demyelination. Okay, it can cause blurred vision as well as weakness in the legs. It can cause diplopia, which is double vision. Okay, it can cause scrotoma, which is a spot in the visual field, or it can cause dysarthria, which is poor articulation. You can also have paresthesia, and this would be areas of numbness, burning, or tingling, and these can be developed if the sensory nerves are damaged. This progressed weakness and paralysis can extend to the upper limbs then, and then basically this can lead to the loss of coordination, of bladder, bowel, and sexual dysfunction, as well as chronic fatigue. This is figure 14.29, and you can see in yellow we have the areas of demyelination that can occur, and then what happens is in the cerebellum it can cause loss of balance, ataxia, as well as a tremor. In the cranial nerve, it can cause diplopia as well as our loss of vision. In our motor nerve tracts, it can cause weakness and paralysis. And then our damage to the sensory nerve tracts can cause that paresthesia, a prickling or burning sensation. So you can see how this affects. And this is, again, page 371 on figure 14.29. So, what can we do for diagnostic tests? Well, there is no definitive test. We use MRI for diagnosis and for monitoring progression. For treatment, we again don't have a definitive treatment that's approved at this time. There are several research trials that are in progress, and the therapy includes physical therapy and occupational therapy, and manifestations require individual attention. Moving on to Parkinson's disease, and we're on the tail end of this lecture. I know we're an hour and 20 minutes in. We have 18 slides left, guys. Let's do it. Okay, so Parkinson's disease. This is on page 372. This is a progressive degenerative disorder, and it causes a dysfunction in the extrapyramidal motor system. And this is due to a progressive degeneration in the basal nuclei. This causes an imbalance between the excitation and the inhibition in the basal nuclei, and this excess stimulation can affect motor and posture. So we can have resting tremors, we can have muscular rigidity, we can have difficulty initiating movement, and we can also have postural instability. So why does it happen? Well, we don't know. Welcome to science, guys. So it's primary or idiopathic Parkinson's disease. Usually it develops after 60 years of age, and secondary Parkinsonism can be caused by encephalitis, from trauma, from a sports injury, from vascular disease, from drug-induced causes such as phenothalazine tranquilizers, right? But overall, we don't have one thing specifically pinpointed. On page 372, we can discuss early signs and symptoms such as fatigue, muscle weakness, muscle aching. We have decreased flexibility. We have less spontaneous changes in facial expression. We also have tremors in the hands at rest, repetitive pill rolling motions in the hands as well. Some later signs and symptoms include tremors that can affect the hands, feet, face, tongue, and lips. You can also have increased muscle rigidity, difficulty in initiating movements, slow movements, a lack of associated involuntary movements, the characteristic standing posture, which is going to be the next slide, and it's stooped and leaning forward. You also have a propulsive gait, partially due to stance, and then complex activities become slow and difficult. So this is figure 14.30 showing the stereotypical presentation of Parkinson's. So you can have the tremor, you can have mask-like facies, right? You can have that stooped posture, you can have like a rigid spiny back, you can have your hips and your knees slightly flexed. The arms and elbows are flexed at the elbow and the wrist. You can have tremors in your hands and your legs, and then you have the short shuffling steps. So other functions that can be affected can be a low voice that is devoid of inflection. So instead of raising and lowering voice, it's just very monotone. Dysarthria can also be a sign, a symptom of it. Chewing and swallowing can become difficult. This can prolong the eating time, and it also can cause reoccurrent drooling. And the face might resemble a mask, where it has the blinking of the eyelids is going to be reduced, and you can have a blank and staring face, and this can impair communication. Other functions can be autonomic dysfunction. So we have problems maintaining our urinary retention, and this can also cause constipation. You can also have orthostatic hypotension, and so basically low blood pressure can cause you to have falls. Your threat of falls can increase, and then urinary tract and respiratory tract infections are also other common complications. And dementia can develop late in the course of the disease. So for treatment, remove the cause if we know what's causing it, but if not, then we can use dopamine replacement therapy such as L-dopa, right? And this is a dopamine precursor, and we can also use monoamine oxidase beta B inhibitors, anticholinergic drugs. Speech and language pathologists can help to maintain pronunciation and speech patterns. Physical therapy can help with the tremors. Occupational therapy can help to improve your balance and coordination. And also we need to monitor and treat the treatment of respiratory and urinary tract infections. So moving on to ALS, this is on page 373. This is also known as Lou Gehrig's disease. And again, we don't exactly know the identified cause, but we do know that there are genes on various chromosomes that have been linked to the disease. We also have progressive degenerative diseases that are affecting the upper motor neurons in the cerebral cortex and the lower motor neurons in the brainstem and the spinal cord. There is no indication of inflammation around the nerves, and cognition is unimpaired. There is a loss of upper motor neurons in the cerebral cortex, and we have spastic paralysis and hyperreflexia. You can have damage to the lower motor neurons, which would cause flaccid paralysis and decreased muscle tone and reflexes. We also have progressive muscle weakness and loss of fine motor coordination. This can cause stumbling and falls, and these would be common in these instances, and death may occur because of respiratory failure. We don't really know how to treat it, so we don't have a specific treatment, but we do try to slow the degeneration. Stem cell therapy is under investigation and has a lot of promise. We can use pharmacologic treatment such as Rosidol to slow the further damage to the neurons. Moderate exercise and rest is good, so balance the two. We also have respiratory therapy and make sure that you're getting appropriate nutrition. And we do speech pathology, occupational therapy, physical therapy, and psychological treatment to help to maintain all of these. So moving on to dementia. So this is on page 375. This is progressive chronic disease, and there's cortical function that is decreased. We can have impaired cognitive skills, impaired thinking, judgment, and learning. It can cause memory loss, confusion, and behavioral and personality changes. There are many different causes of dementia, such as vascular disease, infections, as well as genetic disorders. What about Alzheimer's disease? Okay, this one is a progressive cortical atrophy, and this is caused by neurofibrillary tangles and plaques. Okay, the acetylcholine deficit is caused by the loss of neurons, and so we don't really have a definitive diagnostic test that we can do to say, oh yeah, you have Alzheimer's disease, right? But we do have tests that we can do to exclude other disorders. I'm trying to find that in your book. We also have careful medical and psychological history that is going to be taken so that we can make sure that we are looking at and trying to do palliative treatment. The specific cause of Alzheimer's is unknown, and we do know though that there is a repetitive DNA sequences on different chromosomes that have been associated with Alzheimer's disease. Interestingly enough, they used to think that, well, we have adult onset hydrocephalus, and a lot of times like Alzheimer's used to kind of be misdiagnosed, or NPH, normal pressure hydrocephalus, used to be misdiagnosed as Alzheimer's. But sometimes if they find out that it's adult onset hydrocephalus and they put in a shunt, it can actually reverse the problems. So that's good. So Alzheimer's disease is on page 375, and basically approximately 10% of the population older than 65 years of age has Alzheimer's, and this increases to 25% when you're older than 85 years of age. This is caused by amyloid plaques and neurofibrillary tangles, and this is figure 14.32 on page 376. So The amyloid plaques are going to be basically there, and this is going to cause signaling issues and other neurodegenerative problems. So again, the signs and symptoms can extend over 10 to 20 years. It causes behavioral changes, irritability, hostility, mood swings. It can cause gradual loss of memory, lack of concentration, impaired learning, and poor judgment. It can cause a decline of cognitive function. It can cause memory problems and language issues. It can change your intake of food, and also it can cause the inability to recognize family, lack of environmental awareness, incontinence, and inability to function. So this also is part of figure 14.32, and this is showing the brain atrophy. And so this is a comparison of the normal and Alzheimer's disease brains. So the normal is on the top and the Alzheimer's is on the bottom. So the Alzheimer's disease shows the gyral atrophy and sulcal widening that's seen in a person with no cognitive impairment. So basically what that means is the peaks and valleys, like the dips, the sulci, they get deeper and wider space because the brain is kind of atrophying, right? So it's degenerating in a way. So there is no specific treatment. We can use anticholinesterase drugs. These drugs can cause or can lead to some temporary improvement. We can also do occupational therapy. You can see psychologists, and you can undergo speech therapy to help keep what you have. You have to use a team approach to support the client as well as the caregivers. There are other different forms of dementia, and this is on page 377. There is vascular dementia, and this can be caused by cerebral vascular disease. This is often the result of multiple small brain infarctions. This is common in persons that are older than 70 years of age, especially in those with hypertension or high blood pressure. The onset is insidious, and this causes memory loss, apathy, and inability to manage daily routines. The progression may be in stages, and other neurologic impairment is common. And then the last one we're going to talk about is Creutzfeldt-Jakob disease. And this is a rare disease, and it is rapidly progressive. And so that's no fun. It's caused by a prion that would be ingested or transmitted through through contaminated food. So think of mad cow disease. This is on page 377. It may be iatrogenic, and basically invasive procedures with surgeries like corneal transplants can potentially transfer prions, but I mean, we're better at detecting these and sterilizing, so it's not as common this way. But right when mad cow disease first came out, they were realizing that they didn't sterilize the instruments between surgeries well enough, and so then that caused some transmission of it. But again, we fixed things. Mostly is sporadic. There is a very long incubation period, and Creutzfeldt-Jakob disease can cause memory loss, behavioral changes, motor dysfunction, as well as progressive dementia. Okay, that concludes this chapter, and honestly, they left a whole bunch out, a lot of my favorite diseases to talk about, but I think that this was long enough. So I will see you all in class. See ya.